Good morning, everyone. My name is Margareta Brandt. I'm the Assistant Deputy Director for Health System Performance at the Office of Healthcare Affordability. Thank you for joining our second investment and payment work group meeting. Um, we again have a full agenda today, and we'd appreciate if you all could put your name and your title and your organization in the chat so we can start chatting and get to know everybody who's on the line, including all of our work group members. And we are joined by several members of the OHCA team, including Vishal Pagani, the Deputy Director of the Office of Healthcare Affordability, and then also our partners at Friedman Healthcare, including Mary Jo Condon, Vinayak Sinha, Bob Seifert, Summer Prague, and Julia Sledzik. And thank you all for starting to introduce yourself in the chat. I will bring up our materials. Okay, can you all see that okay? Okay, I see a
Yes.
few head nods, thank you. So so today we'll just start with our agenda, and then we'll go over the work group charter as our first agenda item. So thank you all for everyone who has provided feedback and reviewed the work group charter. Really appreciate it. And then we will start with our second agenda item is use cases for APM measurement. Our third agenda item is categorizing APMs to support California use cases. And then we'll do, time permitting, we'll do an introduction to health equity and APM measurement. We don't want to delay or cut short the any discussion on agenda items 2 and 3. So if we can get to it, we'll get to health equity and APM measurement. If not, we will take that up at our next meeting. And then we will adjourn at 10:30. So just a quick note on our meeting format. Again, we're in Teams please continue to use the chat as much as you'd like. We take note of all the comments and all the feedback shared in chat and use that to inform our work going forward and the discussion here as well. And then for the investment and payment work group members, we're very excited to share that Dr. Amy Nguyen Howell, who's the chief of the Office for Provider Advancement at Optum, will fill the remaining providers and provider organizations work group member position. And unfortunately, Dr. Howell was not able to join us today, but we've shared with her the materials and the work group charter, and she'll be joining us in August. And then we also will likely have a new work group member joining us in August to fill our last seat for health plans. And so getting to the work group charter. So thank you to everyone who provided feedback and reviewed the work group charter. We really appreciate your input and your feedback. The feedback generally fell into these 3 categories. So the first one was clarifying that there will be continued emphasis on all 3 topics: alternative payment models, primary care, and behavioral health throughout the work group's life cycle. So we've added a note to reflect this in the timeline section, and a note here that as the work group moves forward and we develop essentially recommendations or proposals, and we bring those to the advisory committee or the board, we will always come back to the work group to debrief from those advisory committee and board presentations to get further input and share with you what we heard. And then the second kind of general theme of the comments was to better articulate that the goal of primary care and behavioral health benchmarks was to ensure, or is to ensure, sufficient investment and not constrain spending in those areas. So we've adjusted the background in the scope section to reflect this, to better reflect this. And then also to clearly state that the work group will inform the measurement, reporting, and benchmark setting and the standards development for APMs, and we included another note to emphasize this. So you should have hopefully all received with an email, and then also it's available on our website, a redline version of the charter and a revised version of the charter that shows the revisions that we've made. And I'd welcome if there are any questions or additional feedback on the revised version, please feel free to email me with any additions. So I will take a quick pause to see if there's any questions or any comments before we move on to our second agenda item. Okay. I think.
Oh, hi, Margarita.
Oh, yes.
Hi, it's Carrie. I don't know if you can see me. And I'll follow up by email, but I don't really see equity and sort of mentioned or referenced here, and that's just sort of an overall comment. Would love to see, I know that this is not, equity will be a conversation in the larger group as well, but just, want to make sure that as we're thinking about payment and cost and all these other pieces, that we're also thinking about equity as well. So happy to follow up online, but just wanted to share that.
Thanks, Carrie. And that's for the charter that we could better reflect how equity is incorporated into our work in the charter.
Yes.
Okay, great. Yes, happy to follow up, and thank you. So I will now turn it over to Vinayak to kick us off with the discussion of use cases for APM measurement. We have a few spots where we will pause for questions, but of course, if you have a question, please feel free to raise your hand or jump in. Vinayak.
All right, thanks, Margaret, and good morning, everyone. We're excited to delve into some of the APM measurement pieces with you. So just really start us off, we're going to start sharing what data we can collect and from whom OHCA is able to collect APM adoption information, and some of these key use cases to help understand APM adoption. So on the next slide, we just start with a bit of a refresher for the group and to orient ourselves towards getting ready to talk about use cases. And so here's the statutory language associated with OHCA's work on APMs. Essentially, our goal here is to move more payments from fee-for-service to alternative payment models. The work has three major components. The first one is to measure the movement of payments to APMs, then to set a statewide goal for adoption of APMs. These goals may be based on the percent of members, providers, and/or payments in APM arrangements. Third, we will be working on adopting APM contracting standards that healthcare entities can use as best practices in their contracts. And this is really with the goal to help enhance alignment with other state initiatives, and then also to continue to promote quality and health equity throughout our work. So there are a number of different states in the country who are also monitoring healthcare payment models. And we'll talk about some of those use cases shortly as well. But just wanted to set the stage with what we're doing as part of this effort first. And so on the next slide, we actually get to what data OHCA can get to through this effort. And so there's a very specific charge here to collect data and other information from a few different folks, and that includes payers, fully integrated delivery systems, restricted and limited healthcare service plans, and the type of information we're thinking about, are types of payment models and their adoption, information on members and payments flowing through those models, and the cost and quality performance measures used in those payment models. Just want to make a note here that currently OHCA cannot currently collect data at the member level or from provider organizations. And so this means that the current data submitters will be able to provide some insights into the intent of payments, but will not be able to clearly share with us how each payment has been distributed within a provider organization. So just something to note about as we think about these use cases and what we're seeking your input on today as well. And that's what we get to on our next slide. So as we begin reviewing how APM data can be used, we're really asking workgroup members to consider these three key questions with OHCA's APM measurement needs and adoption goal in mind. Part of that is that, OHCA is really interested in collecting any data that will help promote the shift from fee-for-service to APMs. And when those payments provide financial incentive for particularly equitable, high quality, and cost-efficient care. So this is what we're asking you to think about as we go through these next few slides in this section on use cases. So for our next slide, we wanted to just level set to kind of start off with. We wanted to just make a quick note that APMs and non-claims payments are not necessarily synonymous, right? So non-claims payments would be payments for healthcare services made outside of the typical fee-for-service system and that are not based on a claim. And as we talk about alternative payment models, we're talking about payment approaches that incentivize that high quality, cost-efficient care. And so, recognizing here that not all non-claims payments are value-based payments or APMs, and not all value-based payments or APMs are solely non-claims payments, but that there is some significant overlap. We also recognize that there's some nuance between APMs and value-based payments as well, but they're a little bit more similar than just thinking about non-claims payments as a bucket and then APMs as a bucket. So just noting that here, and we're happy to discuss that further as we think about these various use cases. So on our next slide is a little bit of a refresher again on what some other states are doing in relation to APM data. So state interests really vary, and those interests vary based on their data collection authority in each state. And therefore, they may define what an APM is a little bit differently as well and collect data in a more nuanced or different way. Some of these main use cases include understanding the non-claims component of total cost of care, sometimes with a specific focus on high-value services such as primary care or behavioral health. And then similar to California, some states are tracking the movement of payments from fee-for-service to APMs. And so these various states that are collecting data, their lessons learned will really help OHCA identify the use cases to support California's APM adoption goals. And so we keep these in mind as we start to get into some of the California-specific use cases on the next slide. So a first real step in understanding how to measure APMs is to understand why we're measuring APMs. So that interest in APM adoption is pretty broad and can really encompass a lot of different use cases or ways to look at the data and glean specific pieces of information about the different types of models in the state. And so to really understand the shift from fee-for-service to APMs, and while doing that, promoting and incentivizing healthcare entities to use effective payment models, OHCA really is thinking about this in three key ways. The first one is, we need to have a strong understanding of the types of arrangements that are common in the market. Then we'll want to try and assess how effective these arrangements are. And finally, understand their impact on high-value services, such as primary care or behavioral health. So to do that, there are specific use cases that can help OHCA, achieve these three specific things. And that's what we'll be discussing for the rest of our time on use cases. Those use cases outlined here are understanding the level of risk that providers are assuming in APM arrangements, the dollars moving through APM contracts versus the actual non-claims payments made in those contracts, the evaluation of overall financial performance of different types of payment models to really understand effectiveness here, understanding some of the traits and features of the contracts and the organizations participating in them that are performing well. Looking at where different types of APM arrangements exist and where additional incentives may be helpful. And then finally, the percentage of payments for high-value services that are stable and predictable and can really support care delivery transformation in those areas. So identifying priority use cases will really help the OHCA team determine how data is initially collected, how it's reported, the ways that stakeholders might use the data, and then the opportunities to really assess and promote health equity within APMs as well. So that's kind of an overarching piece on how we're thinking about the different use cases. And next up, we'll delve into each of those 6 that I just mentioned. So to get us started, we're starting off with provider risk and contracting. This is the first use case we're discussing, and it relates to how much risk a provider organizations are able and willing to assume as part of their APM contracts. So understanding this can really inform how stakeholders design their arrangements and incent participation in them. So for example here, this can really help support health plans in understanding whether their provider partners may be successful in certain types of arrangements with more accountability for total cost of care. The example that you see here on the right of the screen is from Colorado. It shows that there are few dollars flowing through shared savings. Since providers seem to be successful at succeeding in pay-for-performance arrangements, it may be helpful to consider moving those providers to contracts within more accountability to total cost of care. So just an example here of how that data may be collected and reported. Our next kind of major use case that we think about is looking at the total dollars moving through those non-claims payments. So there are a few different ways of evaluating healthcare payments and APM arrangements. One way is to simply look at all the dollars associated with the contract and then classifying them based on the highest level of risk in that contract. So an example of that would be classifying, all $100 million of a provider shared savings contract as shared savings. Another way to look at that is looking at the actual non-claims payments made as part of that shared savings contract. The latter gives insight into whether the payments are sufficient to incent population and transform care delivery, and incent that participation in that contract. Here on the right of the screen, in this example, you're seeing what we see in Delaware. So even though the majority of contracts were tied to an APM, the actual non-claims payments made to the providers were a very small portion of that total spending. So you're seeing here kind of 2 different ways one might try to understand payments in APM contracts. And we're hoping that we'll be able to maybe glean both of these pieces to really understand how to help with participation and then care delivery. The next use case we'll talk about is on performance of APM arrangements. So as we've discussed, the evidence on the impact of APM arrangements on cost and quality really varies. It'll be important for OHCA to measure performance, to understand where and how to drive increased adoption and inform stakeholders on which agreements are working successfully in California. So here what we're looking at is some IHA data. The IHA data provided highlights variation by arrangement, and I'm sure you've noted the higher total cost of care for professional risk only as part of that graphic in 2021 compared to other years when total cost of care and fee-for-service arrangements is slightly higher. We know we have Dolores with us today as well, and that IHA is looking into this further and really interested in understanding why that may be the case. We want to note that typically when comparing financial performance across payer-provider contracts, the data is typically risk adjusted, and this really accounts for the differences in the health of the population served by different providers, which would be the case mix. So just highlighting here as part of that effort to understand the comparative performance. The next use case we'll really talk about looks at differences by geography. So this use case really focuses on providing some insights into the characteristics of different geographic markets. This will help identify where there may be opportunities to advance APMs and where there may be a lack of access to value-based care. Here we're also looking at some of IHA's data, and it shows that adoption and performance within and across APM arrangements really varies by region. And so that's something that we want to really understand in a state as large as California to really see where there may be opportunities to better understand and incent participation in agreements. And I am seeing a couple questions come across in the chat. And so I think it will be useful for us in a second as we get to our next use case. We'll pause and talk about some of those as well. But I just wanted to get through this next one that is really looking at attributes of those successful APMs. And so it'll really be crucial for OHCA to understand what makes an APM arrangement successful at lowering costs and improving quality. So equipped with that information, California can help shape the terms of equitable, high quality, and cost-efficient care through transparency and recommended contracting standards. That's where our contracting standards work that we'll start getting to next month starts to really come in. Here in this example you see on the right, Avalere Health identified that in 2018, among the Medicare Shared Savings Program ACOs, it was the low revenue ACOs, which are typically led by physician groups, that achieve greater savings per beneficiary than the high revenue ACOs, which are typically led by hospitals and health systems. So given this information, it seems that contracting terms, maybe could be tailored to reflect the differences in ACO ownership. And so I think that that's another piece where we really want to help understand how do we make these APM arrangements in California successful. And I think that Mary Jo just addressed one of the comments in the chat, and part of really talking about some of how we define care transformation and what that looks like. What does that mean in terms of participation in the data we collect? Is really something we'll focus on. How are we categorizing APMs and what does that mean? What attributes result in essentially putting a certain type of payment model into a different type of categorization and therefore comparing it with its like programs. So with that, I think I'll actually move on to our last use case that we wanted to focus a little bit more on. And this is really to say that one of the key recommendations from the recent NASEM report is to move primary care practices to hybrid payment models that provide prospective and stable payments. And so understanding the volume of non-claims payments by the type of arrangement is going to support stakeholders in identifying where and how care transformation efforts in primary care might succeed. So we see this as really key in helping stand up some of these programs. Here, Oregon does a great job here on what you see on the right of collecting that primary care spending data and reporting stakeholders that are able to identify, the providers. So collecting it in a very provider-specific way and identifying, where folks may need additional financial assistance to really transform care, and can then discuss the type of support that may result in delivery of high quality, equitable care that is also cost efficient. Here we're noting that this means really looking at that data in a more granular, nuanced way to understand whether the payments that provider organizations are receiving are sufficient enough for that care transformation to enact a vision for primary care delivery. And just referring back to Bill Barcelona's comment in the chat, as we think about ACOs here, in the previous slide in particular, that was looking at Medicare Shared Savings Programs, ACOs. And so that's specifically what we're thinking about there as a definition. That's the study that Avalere Health did there as well. All right. And so I think that takes us to our kind of next slide. And that really, we want to kind of focus on a couple of things here and then take a break as we think about some of those questions that I brought up earlier. And so first, as we really consider use cases, it's really important to consider how to ensure that there's high quality data collection. Part of that really means collecting multiple years of data each year. It means reviewing those submissions from different entities for consistency, and tracking important aspects of the arrangements over time. We see all of these as really strengthening OHCA's data collection and enabling us to draw some of the conclusions and report on the pieces that we just spoke about in relation to these use cases. So just wanted to highlight for folks that there is a really important interplay between these two things. Reporting on the data and these use cases and what we get out of it, as well as the time and the care taken to collect the right data and ensure that it's of high quality. So on the next slide, we have those discussion questions again, and we'd like to open it up for folks to start commenting by raising your hand. Informed by our input today, this will really help OHCA start to determine what data elements are really necessary in achieving some of these reporting goals. And so with that, we'll open up to any comments and suggestions by workgroup members. Again, feel free to discuss these 3 questions here and make any additional comments that you find would be useful.
So Vinayak, I think you have several questions in the chat, and you may want to start with those.
Yep, sure, that sounds good. I'm seeing the first one from Monica.
Just some of it, I can't somehow get access to chat in the way it's set up in mine, so maybe it would help to repeat questions, or
Yeah.
maybe the moderator. Oh no, here they are. I'm sorry. I stand corrected. Okay.
Not a problem, Dr. Gangapur.
I see them now. I couldn't see
Plan
them.
to repeat them as well. So the first one I'm just seeing here is, are we in this group trying to focus on the biggest bang for the buck with APMs? Meaning where is most of the fee for service spend, and then we focus APM build there. This may change focus area, example from primary care to specialty care, or from outpatient to inpatient. So overall, as we think about this, we're really looking at understanding the landscape and then really incentivizing movement away from that fee for service. Part of that really will be understanding some of the attributes of the organizations and some of those contracts to help establish a baseline of what the landscape looks like now. The second part of that is one of the other use cases that we talked about, which is really looking at performance of these APM programs. If the data is clear enough to say that certain types of arrangements should be favored over others, that may be where that focus area turns to more. In this initial part, we're really thinking about ensuring that the use cases that we're interested in collectively as a work group are reflected in how we'll actually measure and collect the data. So this is that first piece of getting the data in the door to answer some of these questions. Any additional thoughts or follow-ups on that?
This is Margaretta, and I think just maybe generally to share that, there's a few key pieces that we'll be working on. One is data collection, getting the data in the door, and how are we defining like non-claims-based payments? How are we defining versus how are we defining, what counts as an alternative payment model, and then eventually also getting to standards. And in those standards, do we want to recommend like certain types of alternative payment models or certain maybe services that are better provided under an alternative payment model arrangement? So there are lots of different ways we can think about it and lots of different like pieces of the work. So we will definitely be getting eventually over time to like what do we think counts as an alternative payment model, and then how do we set standards or develop standards related to that in terms of best practices for contracting. And then but kind of here in this conversation, we're a little bit starting with like data collection and categorization. So and I know there's been lots in the chat, so please feel free, if you put something in the chat and you want to discuss it further, please feel free to raise your hand or jump in. And I see, Reshma, I see your hand up first, so go ahead.
Yeah, I think I'm agreeing kind of just what you said. There are some models of how to categorize these into tiers. So, I mean, I think the ultimate issue that we're trying to get at understanding for different systems, and it sounds like based on the data we can get it, some of it's going to be self-reported, but from different entities, how much like what is that penetration into their model, right, payment model that gets into either higher level of risk or higher level of like capitation on the spectrum of payment, right? One of those two. So I'm almost visioning like a two-way chart, right? That kind of maps it out in the end of the day. And with that, I've seen a couple models where they get tiered. So like we here at my at UC have like 4 tiers to kind of categorize different types of contracts. And then you can use those as the better marker, because it's not ultimately the specific type of name of the plan or the specific type of name of the program. Even the ACO, I think, gets really tricky and slippery because they mean different things as like 10 of the last comments I've mentioned in the chat box. And so if there's a way to kind of tier that into something digestible, like we use 4 tiers, but something along those lines might be a good happy medium that the state comes up with.
Thanks, Reshma. I think that summarizes some of the comments in the chat really well for us as well. I think what you'll notice is our next session that we start talking about in the next 5 minutes or so is really focused on figuring out what are those categories, what might that look like in California, and how can we use what's out there and being done in different states and nationally to then create something that is specific to these types of arrangements that exist within California, particularly, understanding how much data we can get from our current data submitters on those delegated payments, on the payment flow and the different types of non-claims payments, contained within each of these different types of contracts.
Based on who I maybe saw, Kevin, do you want to jump in?
Sure, thanks. Yeah, I mean, just sticking with the use case issues, because I know the next part of today's conversation, you have all the different frameworks for thinking about different, alternative payment models. So I guess I'd start by just thinking for OHCA, what is the most important priorities for this analytic work? And first would be just this issue of how much money is being spent in California on healthcare and how is it being spent, right? So I think some of this is just to make sure we're getting an accurate enumeration of all the money that is flowing into healthcare. And that really gets mainly to this whole notion of non-claims based transactions or flow of money. And so that's going to be critical for understanding the denominator of total healthcare spend in California, and particularly then when we get into things like subsectors of primary care or behavioral health. So we want a very accurate accounting for both the numerator and denominator. So to me, that would be the most immediate priority for this work, is just to make sure we're capturing that. And to do that, then you need to know what are all the different types of non-claims based payments that we need to make sure we're recording on that. So that's the first order of business. I think then so it's accounting, enumeration, and then understanding the different ways that those payments may be structured. I think second would be equity. Has come up, and I appreciate the comment at the beginning of the session about making sure that's centered. So then it would look, what way it's our alternative payment models, including an equity thrust. So that might be on the front end, is there an alternative payment model that specifically gives higher payments if people, practices or organizations are caring for patients with greater social risk and social needs and things like that. So that would be, again, a descriptive. I think the third thing people have started talking about is, to me, the most ambitious, which is to really then look at outcomes and try to link payment models to performance. And like that's the large health services research project, which I think we can do, but I guess to me, that's a much more complicated question, because you get in what's the methodology and how are you going to do all the risk adjustment to know, is it really the fact that it was this alternative payment model that was related to, let's say, differences in expenditures or quality. But those take a lot of sophisticated analytic work to make sure you're actually making correct or valid inferences. So I would, for us right now, really start by just saying we want to make sure we have total capture of healthcare spend and can begin to put it into the different schemes of alternative payment models to kind of just descriptively understand what's going on in California.
Yes, thank you for those comments. I'd say, starting off with the first one, I think that this group is fortunate that the THCE data collection on total healthcare expenditures comes just a little bit before this data comes in the door. So, we'll have that as a background for what that full denominator looks like, what the accounting looks like, while at the same time, we'll be able to continue to understand how we might want to categorize those, and then eventually be getting that more nuanced information on those non-claims payments. So agree, I think that will be really a first key step in understanding where we are now, just kind of setting the stage. The second piece on equity, we think of equity in a few different ways. That conversation will start today and continue for the next few months. The way that it'll start today is really the focus of today, which is on measurement, and how do we make sure that we're including it in measurement, and then moving on to contracting, statewide goals, and other pieces related to the APMs. Equity will, of course, also be a common theme throughout our primary care and behavioral health work. And so we want to start today by kind of figuring out how to do that as part of the measurement piece, and then really weaving it in throughout the rest of the work that this team will really be undertaking. And then on the third piece, that kind of health services research work, and it truly is, understanding the nuances and the differences between payment models to see what is actually very successful versus others and how to point folks in that direction is going to be something that will take some time. And you're actually helping me make a bit of a point that we had on the last slide, which is to say that some of these pieces will require multiple rounds of data collection to really understand how these payment models are changing, how performance in them is changing over years, what the attributes of the folks who are participating in them are. And so some of these use cases may be better served to be addressed, after the first data collection, just to get a snapshot. Others will take a little bit more time, a little bit more work. And I think that one in particular, understanding the comparative effectiveness of these models, is one that may take a little longer.
Thanks, Vinayak. I think I see Beth.
Hi, Margareta. A couple of points. So first, I'm sorry to say total healthcare expenditures is a subset of healthcare spending. As we've learned in the discussions in the larger board meeting, it is what the payers pay. But for example, a lot of behavioral health is cash pay, private pay, and does not show up in what's called total healthcare expenditures, which is actually a subset. Similarly, what consumers pay out of pocket could show up, but does not in other states. So it's it's an important picture, but I would say not a complete one, and additional data sets will be helpful on that. Second, to go to Margareta's very good basic question, which is what data. I am struck in looking at the geographic variation between our regions of California that are remote and not particularly dense, and the contrast with the much denser regions, primarily along the coast, but also to a lesser extent the Central Valley. And I think it's important, as you're thinking about the data, to use ideally the covered California regions that we're going to be using for reporting, and that are used for rate setting in the commercial market. The other point I'd make is that my understanding is the use of APMs has varied a lot by primary care versus specialist, and has also varied a lot over time. And I think there are reasons why that evolution has occurred in California, and I think this conversation would be enriched by having some of the participants who know much more about that than I do share some reflections on that. Thanks.
Thanks, Beth. Yeah, that's a really good flag about, potentially looking at who's participating in these APMs in terms of provider composition. I think I saw Bill, and I know we have a few other hands raised. Bill, I don't see you unmuted. Let me see if I can.
Okay, can you hear me now, Margareta?
Yes, yes.
Oh, thanks. Okay, great. I had a question about the APM framework and definitions. Are we moving away from the 4-category APM framework that's followed by LAN?
That's a question for this group, and I think we'll dig into that in our next agenda item. But that's very much, I think, overarching and a preview is that we're kind of considering, like, is HCP land, or are the HCP land overarching categories detailed enough or nuanced enough to capture what's happening in California. So I think that's our question for you all.
Okay, thank you.
And I think, Carrie, I see your hand next.
Sorry, I'm just trying to unmute here. I have a question. I'm not sure if this is the right place for that, but I'm curious if we're also looking. I mean, I know the focus here is really on cost, but if we're also looking at you know, the care delivery, the way that healthcare is delivered as part of our measurement. And how that, this is just a general question, like how does that, you know, interact or overlap with the way we're measuring cost of care? Because I think, you know, if we are, and this goes back to, I think, the first person's comments, if we are, you know, really trying to have an impact on on the way care is delivered and ultimately on equity, I think, you know, we also want to be looking at the, you know, the type of the way that care is provided, I guess, in a general sense.
So that is a great point, Carrie. I think part of really what we think about here is trying to marry those two aspects. One are some of those traits and aspects of an arrangement with then the financial performance data that you're collecting as well. There are some examples of how other states are trying to do that. I think California will likely be first, where there's a charge to do both at the same time and to work those in unison. In Colorado, they collect data on the different on qualitative data, as well as quantitative data on the different types of APM arrangements that exist, what types of services are included, what that care delivery includes or looks like, the associated payments, and then of course the quantitative data on those payments. There is a quality component there as well, though not under the same umbrella or the same hat or organization. Maryland has not yet received their data, but they are also structured in a very similar way of collecting both that quantitative and the qualitative to understand the models, the type of care delivered, the specialties included, et cetera. So that'll be part of our work, is really to try to you know, understand all the right types of information from those two types of data collection that will exist under this piece.
Thank you.
Thanks, Carrie. Thanks, Vinayak. And I think Dr. Solomon, do you want to jump in?
Yes, thank you. And I think there have been some comments in the chat about this, and it definitely pertains to some of the things that have said. So I'm hoping I'm not repetitive. But I think that first bullet, this idea of what is important to promote movement from fee-for-service to APMs, is alluding to APMs as if it is a monolith. And I think there's definitely a spectrum there that needs to be considered when we start thinking about the data we're collecting and what's impactful, ranging from an upside-only attributed model ACO through a designated model with upside and downside, through capitated payments, or even between their payment structures where there is a significant case management or fixed payment, and then on top a per service utilization payment. And if we are not clear on where the value comes from, and we lump in that attributed model upside only ACO with the fully capitated delegated combined institutional professional model, then we may be missing some nuance, not collecting the right data, or collecting data and making efforts to push in the wrong direction where we may not get the return that we're hoping for.
Dr. Solomon, thanks for that comment. Wholeheartedly agree. I think part of our next conversation will be really understanding how to capture that data in that nuanced way so that we can come to the right conclusions.
And Reshma or Dr. Gupta?
Yeah, just a comment, and I don't know if this categorizes as measurement or if it just it's, I think, a good thing to think about for the program in general. So maybe a thought for later even, but At the national level for some of the primary care APMs, there's significant amount of discussion upfront about upstart and capacity. So when we're really thinking about moving the needle right from the fee-for-service to APM, this gets not only to the payment discussion, but also a lot of this data is kind of that qualitative piece and just setting up the program in general. But that upstart to get people started, like what that APM model actually would look like, right? Versus the fee for service. So that prior comment about what folks are doing got me thinking about this, is really, really important, because if you don't have that upstart funding to kind of build that infrastructure from an operational perspective, your outcomes are going to be out so far that for policy, it's hard to measure. Like you'll get there in 6 years, but hey, we're only a 3-year program or 5-year program. So the evaluation for like comprehensive primary care, the first one that came out, modest output for the cost side, but great for some of the other things because of the time frame and the upstart. So the future models that came out from CMS had a little bit more upstart. And then that also links to the equity component too, especially around measurement, because some practices are starting from a very, think of rural, think of small independent practices from the comment that came prior in the comment section. That whole discussion is really different. So I just want to point that out, that the upstart use case is what I'm calling it, but I don't know what you want to call it. But that idea is super important if we're actually going to try to move the needle in a measurable way for policy.
Thank you. Yeah, that's definitely a key consideration. I think we'll maybe take this back, think about how that might coordinate or tie into data collection, but I do think it's an especially important point for the standards, and thinking about what we include in those standards.
Yep, agreed here. And I'm noticing, I think, a few of our comments as we're thinking about, the use cases are really now focusing into how we might categorize these APMs, define them, how we'll collect the right data to ensure we can answer that use case. And that really is kind of the next agenda item. To support that understanding, the first step really is to collect the data, to categorize it appropriately, as Dr. Solomon mentioned, to figure out those associated payments for whether it's that particularly high value piece of the delivery or something more nuanced. And so Mary Jo's going to walk us through some of that now. So Mary Jo, I'll hand it off to you.
All right, thank you, Vinayak. As Vinayak mentioned, next we're going to discuss approaches to categorizing APMs. An important piece of this work is thinking about how to categorize the non-claims components of these arrangements, and then also how to categorize the entire contract, right? So often the contract includes a non-claims component and a fee-for-service component as well. So let's go to the next slide. So across OHCA, there are 4 efforts related to non-claim spending, and all of these are occurring on a sort of parallel track. Each has a different purpose and a different use case. So first, there's the total healthcare spending target. And this work is really focused on collecting data on non-claims as well as claims and other expenditures to quantify these payments as part of total spending. Then it categorizes those payments to answer questions such as what's the purpose of the spending and what are we buying? Is it of high value? Next, there are the 3 work streams that are related to our work. So first, the primary care and behavioral health investment targets. Basic question related to non-claim spending is how much in terms of non-claims are we spending on primary care and behavioral health? And then also, does the payment structure support those care delivery goals? So for example, we've talked a little bit this morning about the need to have that upstart revenue, right? To sort of help build the infrastructure, help sort of prepare the care team for care transformation. On the APM side, some of the questions that Vinayak just went over. So how much risk are providers taking on? And is it doing anything to improve care delivery, value, and equity? I think those are really important questions. And then the last effort that is occurring across OHCA is does total cost of care vary by provider organization and service type? All right, so let's go ahead to the next slide. We wanted to sort of share with you up front a couple of the questions that we are going to be asking for your input on. So as we sort of walk through this presentation, if you could sort of keep these in mind. One is that, based on your knowledge of California APM arrangements, will the following framework work to capture these types of arrangements? And then also, what type of guidance will be helpful to payers and other data submitters to accurately categorize these payments? If we go to the next slide, as has been mentioned, there are some national frameworks that are commonly used to measure different types of non-claims payments and APMs. So if you go to the next slide, the first one I'm going to walk through is the Milbank Memorial Fund. Initially, this was designed to measure non-claims primary care spend, and it has evolved to support states in tracking total healthcare spending, including non-claims. It really focuses on the purpose of that use case, which is to understand why was the payment made, what was the payment's purpose. And it's really nice if you're tracking spending on things like, for purposes like the total healthcare expenditures, because you can sort of answer that value question, or at least begin to answer that value question. The next, which was referenced just a few minutes ago, is one that I know many of you are familiar with, which is the Healthcare Payment Learning and Action Network. And the purpose of the HCP LAN framework is to track and promote APM adoption. The framework is designed to categorize payments according to the level of risk taken on by the provider organization. And the use cases for this framework include, how do we define value-based care? For the purposes of contracting, for example, many Medicaid organizations contract and include this framework as part of those contracts. And then also, how do we define state APM adoption goals and measure progress towards those goals, which is, a couple of the use cases that Vinayak referenced just a few minutes ago. If you go to the next slide, we started off with this idea across the OHCA and FHC teams of, could we crosswalk these national frameworks? Could they sort of be overlaid on top of each other? And if in doing so, could we develop an option for California that would essentially allow you to fulfill all of those HCA use cases that we saw on that initial slide? I really liked one of the stakeholders in these conversations described it as like a convertible method, where, if you look at it one way, you can see sort of the purpose of the payment. And then if you flip it, you can look at it the other way and see what was the level of risk that was taken on. The next step in this work was to update the payment categories to reflect the common payment types in California. And we work closely with Dolores at IHA, who I think many of you know. She's on our team, and she and the work of the IHA Atlas really informed this part of the process. And then we went back and we revised the structure again to sort of realign the risk progression and the payment purpose, so it again works sort of along a continuum. So what if we go to this here? This is sort of a high level overview. This is very much draft. This is something that we're just sort of, working through. We may use this, but really want to get your input on it. A few points to sort of recap and consider here. That this, what we're calling as of right now, a unified framework, basically crosswalks the Milbank framework and the HCP LAN. Again, the purpose is to have a single framework that will support those multiple use cases, including defining the payment purpose and also measuring and tracking the amount of risk that's being taken on by the provider. It also, as I mentioned, updates and sort of refines those Milbank categories and subcategories to better reflect care delivery and payment in California. For example, there's multiple different types of capitation, et cetera. Another piece that I want to clarify is that this tool would be designed to capture non-claims payments and the portion of total spend level by provider risk. So as Vinayak and I have supported other states in collecting alternative payment model data and non-claims data, we think it's really important to understand both the amount of the non-claims payment and also the total value of the contract under the APM. These are really different things, and both provide incredibly important insights. All right, I think we have just one more slide, and then I want to stop for some questions and comments on this. And I know we also have some comments in the chat. So I want to take just a minute to walk through each of these 4 sort of major categories and associated subcategories. Again, this is draft. This is just something that we're sort of putting out there for discussion and to get your input on. 4 categories: population, health, and infrastructure payments. You'll see there some of the flavors there: care management, primary care and behavioral health integration, social care integration, practice transformation payments, HIT, analytics, infrastructure, sort of those capacity building payments. Now, one thing I'll tell you that we've been supporting several states in similar work, and it's important to get the definitions right? So, we've begun drafting the definitions. I think that's going to be a really important part of the work as well. The next category is around performance payments. So these are just, sort of classic payments. The example that most comes to mind for me is sort of the primary care provider that is given a couple of dollars per member per month for a certain level of HEDIS performance. And then you have all sorts of types of payments with shared savings and recoupments. And so we have some different types of episodes, so procedure and condition episodes, both with shared savings and with shared loss, and with risk of losses. And then also those sort of total cost of care accountability programs, similar to or sort of modeled off of like an MSSP chassis. And then the last column here, the last category, are full risk and capitation payments. And so some of the flavors of subcategories that we've come up with so far include primary care capitation, professional capitation, facility cap, behavioral health cap, global cap, and then integrated delivery systems. One of the sort of nuances or challenges or trade-offs is thinking about, what type of payment is sort of common enough and distinct enough that it rises to the level of being its own subcategory without having a million subcategories that, makes data collection really complicated. So with that, I want to just take a pause, see if our workgroup members have any questions, would like elaboration. I know that we also have some comments in the chat.
Yeah, Kevin, please jump in. Dr. Krumbach.
Kevin's fine. I like your schema a lot. I think this is very helpful. I like how you synthesize them. My only question, Mary Jo, is that final column under full risk and capitation payments, integrated delivery system. Integrated delivery system to me is a delivery model, and it can take all sorts of different payment models. So I'm just thinking, if you think about Kaiser Permanente, then it's global capitation for the whole Kaiser Permanente integrated system. If it's UCSF Health, it would be all sorts of different payment models coming into an integrated delivery system. So I'm not sure whether that belongs there as a payment model.
No, that's great feedback, and definitely how to handle the difference between global capitation and integrated delivery system is definitely one of the places where we specifically would like some input. So really appreciate that. Thank you.
Yeah, I would probably, I think you'd have to make a case why that's a payment model category and not the delivery organization category. And maybe specific, I think, would you say Kaiser Permanente would be global cap? I think, because then.
I think
I think
that's one
that's
of the
probably
questions.
yeah.
Yeah, is to think through if that's sort of its own or part of global cap. But happy to, everyone always wants to add categories, so love feedback to remove one. Margaretta, I know Catherine has her hand up. I also
Yep.
see a couple of questions in the chat.
Catherine, please jump in and then maybe we can go to the chat next.
Sure. So one thought and one question. First, just want to underscore the importance of using Millbank and HCP land for exactly the reason mentioned. They really try to quantify different things for different purposes, and both are essential, I think, for our goals. BAILIT's really about how the money is spent. Is it salaries? Is it hospital fees? Is it what? Right? It's a what type question. And then HCP land is about how, the mechanism for how those dollars flow. So just wanted to underscore that. The second question on this slide specifically, really appreciate the population health and infrastructure payments, and particularly the inclusion of practice transformation payments. And I think that's one that really warrants more time, attention, and some better definition, both about the what and the how. What is that intending to do? Is it supposed to reward practices that have transformed and are providing excellent care? Or is it to provide necessary infrastructure support for those that are struggling, who haven't had the resources or support, and really need to make significant changes to do well in an APM and to deliver the type of care that we want in California? So I think that's worth some time. And then that also brings up a whole set of questions about who pays for that and how that's collected and analyzed. Today, if you look at those types of payments in California, most don't come through plans in traditional ways. They come through community benefit. They come through undertaking. They come through philanthropy. They come through other sources that aren't necessarily tied. And so I don't know the options there, but I think that's worth thinking through what it is you want those dollars to do and how much you want to invest in tracking the payers and the amounts and how that all flows in a way that is sort of fair in an accounting as we think about infrastructure overall.
Great points, Catherine.
I think there was some, maybe, I think Bill had a note in the chat about tracking to the HCP land principles, so we can definitely follow up and dig into that. And then Katrina mentioned, understanding or identifying the purpose of payments, and maybe that goes a little bit to Catherine's point as well of, are we promoting behavioral health and primary care integration, addressing social determinants of health? So really good point. And then I think I thought I saw Joe's hand up. Joe, do you want to jump in?
Sure, yeah, thank you. Joe Castiglione from Blue Shield of California. So I really appreciate the nuance of this unified framework and the crosswalk that you put together, particularly Millbank's focus on non-claims primary care payments. I think that really gets at some of the nuance that HCP or that the land framework lacks. I would also comment that the land is the standard against which others are holding payers accountable. Covered California comes to mind. So just want to note that this is sort of a proliferation of standards. As a payer, we have developed an internal methodology that through work with our actuarial team to make sure that we're reporting out on these categories appropriately. So I guess I also, one other piece I note is that moving away from the land categories, does that lose the ability to look at California as sort of an apples to apples comparison across the rest of the country, right? Because land is sort of the federal standard. So I wonder if you have any comments on sort of that dynamic of course, wanting something that better suits the needs of the unique California market, while also sort of moving away from the federal standard that allows to which we're held accountable by other organizations, and then also allows for fair comparisons across the country.
Sure. Thanks, Joe. Margaretta, could you go to the slide before this one for a second? Joe, I don't think of this as moving away from HCP land at all. I think of this as having sort of an integrated approach that allows you to crosswalk these categories listed here with a corresponding HCP land category. And so essentially for any category that would be measured under the unified framework, there is a corresponding HCP land category that you can convert that to. And so, you know, I actually think that the purpose here is to maintain that alignment with HCP land while also having the ability to better understand some of the specifics of how dollars are spent.
Oh, okay, that's helpful. And then when you report out on these categories as part of, public transparency, do you see reporting on that according to the land categories, or are you also, trying to use this crosswalk to where you can report it on a more granular level?
I think that's a great question. So here's how I might see this happening, but I'll say that, we're sort of very early in the process. So this is just kind of some brainstorming, as how we think about it. But for example, let's say that you have, $100 million contract that is all part of a shared savings, risk for total cost of care agreement. If you were thinking about that in terms of measuring APM adoption, all $100 million would be categorized under that 3A and maybe reported as both risk for total cost of care with shared savings, 3A. On the flip side, though, within that total contract, there may be a lot of different types of distinct non-claims payments. So, for example, there may be some of those practice transformation payments to help the primary care providers within that ACO achieve those shared savings goals. And so, from a non-claims payment data collection perspective, those distinct dollars would be captured as that distinct category.
Okay, thank you. That makes a lot of sense. Appreciate that.
Absolutely.
And Reshma, I see you had your hand next, and I think there's lots of conversation in the chat as well.
Yeah, so my comment, I think, goes back to the last slide. I want to say where it had the different boxes for the different categories. But it goes to kind of the first column there about pop health infrastructure payments. So this is just, I really like, I would have picked the same two that you guys picked to kind of put these together in terms of, so I like music to my ears in a lot of ways. So thank you for all of that work, because I know how hard it is to integrate like these conceptual models. But one other one specifically is around infrastructure payments, which is a good one that I'm very familiar with from the CMS side. But just a couple of things that is just more of a idea to throw into discussion. But so there's a couple other areas around what I call linkages, but it's like the linkage that goes into access and continuity around practice and dialysis centers, care at home, care compacts. I'm thinking rural settings and equity around specialty services. So they may fall into one of these boxes, but they may not. And so I just want to call those out as opportunities in terms of moving the needle from an operational perspective, but it may actually fall into one of these. I'm just don't have the exact definitions. One other thing is just within that same area, HIT analytics infrastructure, there's two things to call out there. One is around sustainable improvement, and the other is use of accountable care payments or alternative model payments. So there's a lessons learned from practices that have tried this elsewhere is a lot of practices don't have that training of how to actually use the funding when they get it from the state or the government. And so that actually comes out from practice leaders all the time. And so it may fit into analytics here as a bucket, but I think it actually is like important enough of we developed this program and it doesn't work. Why didn't it work? That might be one of them that it might be good to kind of lessons learned put in here. One other thing for the right column of full risk and capitated payments, another category is specialty capitation, which there's smaller models for those. It doesn't quite fit into primary care capitation, but I mean, it could be combined, or it could be a separate call out. And then one last one, which you all know I'm kind of biased on this, but the patient out-of-pocket component doesn't enter this clearly, and it's not part of most models. So it's just a decision from the state about how big of a bite we want to take on that piece or not. But I just wanted to call that out.
Thank you. Really great comments. Appreciate that, and also appreciate that HIT analytics infrastructure bucket is tricky. For example, I think one of the decisions to make is, sort of what infrastructure investments count, right? What analytics investments count? Who has to make the investment? Who has to own the technology? It's a tricky bucket overall. And so maybe sort of having some more granularity there would be helpful. Really appreciate that. Thank you.
Thanks, everyone. And I did want to follow up on just one question or comment in the chat. And maybe Dr. Solomon, if you wouldn't mind speaking to this a little bit more for, HCP land versus Milbank. And I think my follow-up question would be, are the Milbank categories helpful in terms of kind of categorizing or collecting non-claims-based payments? And how do you think about that? Or if you wanted to expand on your note in the chat.
Sure, thank you. So for example, let's take that first column there. The way that funds are spent on care management infrastructure, whether that be having care managers or implementing programs that wouldn't normally be able to bill for their services to wrap around the patient to support the actions of primary care. I think you had them categorized as 2A, but realistically, those could be in category 3A or 4B, or is that categorization in the land framework helpful when I'm looking at the value of these items? And as I was thinking about it, I was thinking, I don't really care. If the question is, have you progressed along that line? Then I think the land framework is helping me to assess, are we moving further into these deeper APM arrangements of risk? But it doesn't really answer the question of what are those things that we're pursuing that help improve outcomes. And it goes back to the comment earlier. The assumption is, and I agree with it, so I'm not saying it's not true, that APMs will help improve quality and reduce costs over time, but all APMs are not equal. What are those funding mechanisms and activities that most benefit patients in all aspects of their health and life in California? And so I'm thinking this framework actually has more benefit to Milbank than overlying it with land. I think they're both important, but I don't think they need to be integrated together because they're somewhat measuring different things. That's what I was trying to say.
Dr. Solomon, thank you so much for that comment, and completely agree with you that they're measuring different things, and also completely agree that there's sort of a need to measure both of those things, right? So to your point, one thing that's really important to measure is, and Margaret, would you mind flipping back to the previous slide for just a second? So you're absolutely right. One thing that's really important to measure is sort of that how much risk are providers taking on? That's one of the things that the state needs to measure as part of APM adoption measurement, right? And so the HCP land categories really help us do that well. That's sort of their orientation, is to measure what is the level of risk. However, what we have found over time is that sometimes risk arrangements have an HCP land categorization that's relatively far along the continuum, but there's not much non-claims dollars going to those providers to really sort of transform care delivery. And so what you end up having then is a market where you have, 70% of contracts in an APM, but you don't really have care transformation because you haven't really changed the underlying payment mechanisms. You might have a risk shared savings arrangement with a small opportunity for savings, but it's not really enough to move the needle. And the practices don't really have the infrastructure, population health payments, and other types of payments to sort of transform care delivery. So a goal of this is to be able to sort of measure both the amount of money that is sort of moving through each of these categories, and also at the contract level, how much risk are providers assuming? So I think we're saying the same thing.
I agree, and I'll give you a specific example, maybe. So we would be in, or we were in an attributed model ACO with upside and downside shared savings risk. So essentially a 3B type of model, and implemented similar, if nearly identical infrastructure and support for those patients as we had for our fully capitated managed care model. But the outcomes weren't the same despite our expenses, because the model itself impacted how well we could perform on that population. So I agree. I think we're agreeing, and it's going to be hard, and I'm not an expert enough to know how to piece out which are these aspects we really want to measure when. I think they are all valuable, but they're a family, they're related, they're not exactly all the same line.
Yes, agreed.
So and we have about 10 minutes left. I just wanted to pause to see if anyone else had, questions or suggestions related to this potential unified framework. We will have put together essentially like a handout or a one-pager that lays out, HCP Land, Millbank, the unified framework, and we'll be sending that out to you all. So you have, something to refer to, something to think about following this meeting, and we'd welcome any, written feedback you all have. But yeah, and it looks like Beth, you want to jump in?
Yeah, just thank you. It's been a very rich conversation and very helpful. Back on Kevin's Grumbach's earlier comment about Kaiser Permanente, and they certainly receive global capitation for their enrollees. I think when you think about how the money flows among the elements of the Permanente system, and there are others far more expert than I am on this, whether to the Permanente medical group or the hospital system or the health plan, then I don't think we should just, it is a different model, but it is, it may not be as cut and dried as it seems from the outside, is all I'd say.
Thanks. Yeah, I think that's something we will continue to wrestle with and probably involve some conversations directly with Kaiser.
Yeah, and the other point I'd make, which we made in comments, is we appreciate the use of the HCP LAN and the recognition of degrees of risk, because that goes hand in hand with the need for when there's a lot of risk taken, there should be some financial oversight. Let me just say it that way.
Mm-hmm.
Thanks.
Thanks, Beth. So let's see. I think maybe with our last 10, or sorry, Carrie, did you have a question?
Sorry, I think you might have just been addressing this, Margarita. Just wondering if we're going to be talking about the health equity component today, or if maybe it warrants a longer conversation. I'm just concerned that we won't really have time for the conversation if we jump into it. So just, I'll defer back to you.
Yeah, thanks, Carrie. I was just gonna think about that. And I think maybe what we'll do in the next 5-8 minutes or so is just maybe, Bob, if you want to do like a really high level like introduction, and then we'd welcome people to think about these slides, come back to the next meeting with thoughts, or you're welcome to email me in between meetings with additional thoughts. And maybe, Bob, if there's some kind of key questions or things you wanted to leave people with to come back for the next meeting.
Sure, I think I can get us that far in 7 minutes or so. It's a much more than 7-minute topic, obviously, as many of you have pointed out so far this morning. But let me get a start, and we will pick it up again at the next meeting. So let's actually, if we could just go, yes, right here. Thank you. Just want to sort of start with a little bit of framing about how equity is being considered by payers and health plans, and it's sort of at different levels. They're at a strategic and planning level by elevating equity as an explicit goal, and we've heard a lot about that among you this morning. It's at a plan design level by allowing flexibility to provide supplemental benefits, for example. It's at an operational level with screening tools, improved data collection, and quality measurement. And then what we're most concerned about for our work is adjusting payments in an alternative payment method to motivate improvements in equity. So just to get to Margaretta's point about questions to think about for our next conversation on the next slide. As with the earlier topics today, we want to pose these questions for you to consider as we get back to the rest of the material later on, and we'll take this up and there are other slides for you to consider, for you to look at that you received in advance. I can talk through them a little bit more when we meet again, and then move the conversation forward. But these are the questions we suggest that you give some thought to. So first, how should APM measurement incorporate equity considerations? Should the measurement and reporting of APM results adjust for differences in health status and social needs? So not talking here about adjusting the payments themselves, which is another aspect of equity in APMs, but whether the measurement and reporting of APM adoption should take those factors into account as well. And then a third question, what should APM contracting standards include to encourage equity? And that's another sort of entire category of consideration for this work group. Shall I stop there, Margareta, or carry on? Just want to sort of think about what the time, what time is allowed here.
Maybe we could do one more slide in terms of the examples, and then we'll stop there and ask for if folks have suggestions or thoughts they want us to consider as we go to our next meeting.
Great. Okay, thank you. So within that payment adjustment category, that the fourth one on the 2 slides ago, there are a number of strategies to look at. So these include, number one, requiring health plans to improve the data that they have on members' race, ethnicity, language, disability, sexual orientation, and gender identity. Measuring equity, of course, means being able to measure access and outcomes stratified by those subpopulations, and the current incompleteness of that data in most places hinders this. So some Medicaid programs in particular have offered an incentive to improve the data. Secondly, paying for performance on administering a social risk screening tool, fairly straightforward example there. Third, offering incentives for health plans to partner with community organizations that might address certain health-related social needs. And risk adjusting, finally, risk adjusting the payment amounts for social factors So the payment amounts themselves, in addition to the traditional payment adjustments that are made for clinical factors such as chronic conditions and demographic factors such as age and location. And there are a few examples of those kind of social risk adjustments now in APM payments. When we come back, we'll provide some examples of all of these incentives, or there are examples in subsequent slides here that I encourage you all to take a look at. I can elaborate on them when we meet again. Let me stop and see if there are any preliminary comments on or issues that you'd like us to take a look at now that we have the luxury of another 4 weeks to consider these questions. Please let us know what you think.
Thank you. I think I saw maybe Dr. Soni's hand raised first, and then Carrie and Reshma.
Thanks. Just quickly, in our expanded definition of infrastructure, would love for us to think about workforce investments, loan forgiveness, a number of things that are happening in this space as a pathway to equity. Because I see these examples here, but that's a whole other conversation that is interesting to have.
Thank you. Yeah, Carrie, sorry.
Yeah, thanks. And I don't know if you have looked at, or if this is part of the consideration, but there is there's some guidance that was released recently for equity-centered design and implementation of APMs by the Health Equity Advisory Team for the Learning Action Network. And so I just would like to make sure that you're thinking about that. And to Dr. Soni's point, I think, part of supporting, practice, part of health delivery system transformation is supporting practices and practice transformation. And that also, involves, working with community health workers as part of care teams, and partnering with CBOs, and a whole host of different types of systems measurement and changes that we would want to hopefully see as part of this work. And so just wanted to flag that for you, and I look forward to a longer conversation on this next meeting.
Great suggestions. Thank you very much.
And Dr. Gupta?
Sure. So my comments are mainly focused on the care transformation supporting this work. So I just typed it out in the chat as well, but I kind of categorize in a couple different areas. So one, again, is that startup funding and infrastructure, but this idea of, do we want to, I like that the terminology, I think, from the prior slide about flexibilities. I think that's what this gets to. So the flexibilities around practices that are starting from a different starting point, that have more vulnerability in terms of what their, year-to-year kind of revenue is or lack of, and that investment part. So different tracks or kind of a training model, like just in the infrastructure of the structure of the design of the model, I think can get people ready, or having that first year be that startup without as much, depending what we're talking about is how to hold accountability around these contracts for penalty or anything. And then it's a measurement that I think we already talked about, but I think there's one thing to mention around all of these areas is something we talked about a couple of meetings ago, but what do we want to allow for local variation and learning, and what do we want to be prescriptive about? And I think because we're at the state level, there are definite trends, but it doesn't mean every single practice locally with their own patients has exactly the same trend. There might be another kind of burning platform around equity for them. So it's kind of saying, are we okay with a process improving and allowing them to self-identify an area, which different groups do across health systems? Or do we say that these are the things in the state that need improvement, and even if you have a different burning platform around equity, we're still going to make you work on these three or something? So just something to think about for that, and then calling out social needs a little bit differently around that. And I really like this framework around the partnerships too, but I think those last three there would be some pushback around local, the localness of what's kind of recommended, and innovation in those areas.
Thank you.
Yeah, thank you so much, Dr. Gupta. And I know I'm apologies to cut this short, but we hopefully this was at least a good preview of what we will be covering next meeting and expanding on. So we'll take all of your comments and expand on the slides. And again, feel free if you have comments or suggestions in terms of either the health equity conversation in alternative payment models, or and also in terms of the unified framework we presented. We'll be sending out a follow-up email, and please feel free to share any suggestions or feedback with me via email. And I think with that, we will wrap up for today. Thank you all so much for your participation and your comments. Again, we capture all the comments and use them to inform our work. So thank you so much, and we will see you next month and look forward to communicating via email before then. Thank you all.